Hi, I'm Peter Kowey from Lankenau Medical Center and Jefferson Medical College in Philadelphia. Today I have the pleasure and privilege of talking to one of my good friends and colleagues, Ken Ellenbogen. Ken recently, and his colleagues recently completed a clinical trial dealing with AV delay. Ken, where did this all come from? What's the background on why this trial was conceived?
Well, it's actually sort of interesting. It's already been 12 years since the first CRT devices have been implanted in this country. And if you look at the clinical trials and the outcomes of patients who get CRT therapy today, and you look back 10, 12 years ago, we are really bothered by this problem of non-responders. And it's a significant percentage of patients. About 25% of patients don't respond to CRT therapy. Well, there are a couple of potential explanations. One is patient selection, wrong patients. Second is wrong lead position. And a third one is wrong programming. So despite all these clinical trials that have shown benefit, there are a wide variety of ways of programming these devices. The purpose of the clinical trial was then to compare 3 different methods for programming the AV interval in CRT-D devices and try to see if one was superior to the other. The 3 methods we chose were naturally out-of-the-box setting, that is 120 milliseconds, no programming, just throw it into the patient. The second arm was the arm endorsed by the American Society of Echo. And the American Society of Echo actually recommends that all patients who get a CRT device undergo echocardiographic optimization of the AV interval. They recommend using this so-called iterative method, which looks at the Doppler of the mitral valve inflow and uses the optimization of the ENA waves to pick the best AV interval. And the third method is actually interesting. It is based upon work done in the late 1990s in the electrophysiology lab. Many of these studies were done by Dr. Riccio in Europe, where they used a Millar catheter to measure dPdT at different AV intervals. And then Michael Gold went ahead and used this algorithm to prospectively acutely measure dPdT and show that it optimizes that. Of course, these are supine patients lying in the EP lab. And just so you know, the algorithm incorporates the LV lead position, the QRS duration as measured by RV-LV timing, and the AV interval. So that's the rationale for the study.
So how did you decide on your primary endpoint for the trial? What was it that you wanted to know from the study, and how did you go about randomizing the patients?
So we enrolled over 1,000 patients. Somewhere close to 300 patients completed each one of the 3 arms. It was a 1-to-1 randomization. Patients and doctors were blinded to what arm the patients were actually in. It was an international study over 100 centers, United States and Europe. And the question is great because no one really knows what the best way to measure response to CRT therapy is, but many studies look at LV and systolic volume. We were doing echoes at a baseline 3 months and 6 months, and we said we'll look at LV and systolic volume at 6 months and compare the 3 different methods for optimizing AV interval.
And what did you find?
Well, we found at the end of 6 months, each one of these 3 methods were equal in terms of LV and systolic volume reduction, that there wasn't one method that was superior to the other. There was no statistically significant difference between that. That's for the primary endpoint. The secondary endpoints were both structural and functional. Structural, LV end diastolic volume and ejection fraction. And again, looking at AV optimization by the 3 different methods, they were the same. Now, in terms of functional endpoints, we have New York Heart Association functional class, 6-minute walk time, and quality of life measured by the Minnesota Living with Heart Failure. Again, no difference in any of the 3 methods.
And so what should we take away from this clinical trial, Ken?
Well, I think the first take-home message is that we can save our patients both time and money. They're really, based on this trial, we can say routine, across-the-board optimization of AV interval programming for patients who have CRT devices implanted. It just doesn't result in a different outcome, so why should we do it? It doesn't mean that patients who don't respond to the therapy shouldn't have a good look at their AV optimization. But I think those are the 2 main messages we learned from our study.
Ken, it was a great lesson in clinical trials and a great result, very clear result. I want to thank you for spending some time with us today. Again, this is Peter Kowey reporting on the SMART AV trial.